We're going to be discussing adult immunizations this evening. And actually, you're more likely to die of a vaccine-preventable disease as an adult than you are as a child. And childhood immunizations are incredibly important, and actually when we immunize children, it not only protects them, it protects adults also. We're going to actually cover all these vaccines this evening, briefly. And that is an electron micrograph of the influenza virus. And influenza got its name in Italy in the 1700s because the illness was thought to be caused by the influence of the stars. And we have thousands of deaths and hundreds of thousands of hospitalizations every year in our country because of influenza. Who gets immunized? Everybody over the age of 6 months. And we have a lot of products to choose from, which we can immunize patients with. We're not going to go over each one of those, but I'm just going to give you some highlights. Very important, pregnant women, very important to immunize them against influenza. It not only protects them, but it protects their newborn infant if it's given in the 3rd trimester. So it's very important to immunize pregnant women. Healthcare personnel, very important. Anybody who's dealing with patients, not just doctors and nurses and medical assistants and PAs, but anybody who's around patients should be immunized. It protects the person, but actually, even more importantly, protects the patients, because they're very susceptible. Some are, if they're older or very young and the very old, are very likely to get sick, end up in the hospital, and even die if they get influenza. So, live attenuated influenza virus, the flu myth. So we haven't had it for 2 years, but this year it's coming back. Okay, so it will be back. Let me just go back to that. It's only approved through the age of 49. So if you're over the age of 50, I can't get the nasal influenza vaccine. If you're pregnant, you can't get it. If you're immunocompromised, you can't get it. And it's a relative contraindication if you have asthma. You can give it, but it's relatively. So it's got its niche. It probably should be reserved for people who just are needle phobic and refuse an influenza vaccine otherwise. And as I alluded to earlier, the majority of deaths due to influenza are in patients who are elderly, and the majority of hospitalizations are also in patients who are elderly. So what are our options for elderly patients? What can we do to better protect them? There are 3 options. High-dose influenza is the same thing that's in the regular influenza shot, and it's only approved for 65 and above, and it gives a slight advantage. So it's not recommended over a regular flu shot by the Advisory Committee on Immunization Practices, but it's an option for your patients. You get a little bit more reaction. More people get swelling and pain and redness at the injection site. Fluad's another only 65 and above vaccine. It's supposed to just giving a greater quantity, 4 times the quantity. And this one, what they do is they give an adjuvant. They add something to the immunization to boost your immune response to it. It's been used in Europe for many years. Also has a slightly greater efficacy than just the regular dose flu shot. So it's another option for people 65 and above. And the third, this is not for people 65 and above. Most flu vaccine are grown in eggs. This vaccine is not grown in eggs, or a recombinant vaccine. It's actually approved 18 and above, but as you can see, it's got 4 times the antigen dose as a regular flu shot. And so some studies have shown that in the elderly, it gives you a more robust immune response and possibly slightly better protection. So these are 3 options that we can offer our highest risk patients that may give them better protection against influenza. So sometimes influenza hits the news, right? It's on the media, on the cover of Time magazine. Why is that? Well, there's been 4 pandemics in the last 100 years. And the most recent one was in 2009, 2010. But by far, the most catastrophic was the Spanish flu. And that was in 1918, 1919, during World War I. In our country, it's estimated that it killed about 500,000 people. In the world, it's estimated that it may have killed between 30 and 50 million people, which is an enormous death toll, more than World War I and World War II combined, right? So it's that was a huge pandemic, most in recorded history. So the influenza virus is kind of like a stem with a ball. It's got stuff on the head of the virus. So hemagglutinin and neuraminidase, like when we talk about H1, N1, that's what they're talking about, hemagglutinin and neuraminidase. Hemagglutinin it's what allows the virus to attach to your respiratory epithelium. And neuraminidase is what allows it to jump from cell to cell. So we actually have medicines that we call neuraminidase inhibitors, like Tamiflu. And the reason they work so much better earlier is once it's jumped to too many cells, it's not going to work so well. So those are anti-flu medications you get, and that's how they work. And those are the antigens that we use in the vaccine. So the difference between antigenic drift and antigenic shift. Shifts are rare, drifts are more common. A drift is there's a slight change in some of those antigens, very minimal change. When that happens, the flu vaccine doesn't work as well, and you may have more influenza hospitalizations and deaths that year, but it's only a slight change, so people have some protection. When there's an antigenic shift, that usually comes from the animal population, and we have not been exposed to that before, and that's where you run the risk of a pandemic. That's what we're really worried about. Those are rare events, 4 in the last 100 years. But it's a big concern, and that's, you've heard on the news, H5N1, those are ones that we've never been exposed to that can cause a pandemic. This is going over, so most influenza virus that we give to patients grown in eggs, it takes 6 months. So we have to make an educated guess. What are going to be the most likely strains? There's, in our country and in other countries throughout the World Health Organization, CDC, they get together and they sit around and say, these look like the most likely strains that'll circulate this year. Sometimes, vast majority of the time they're right, sometimes not, and then you have a mismatch between the strain and the vaccine we give. Sometimes you hear that in the news, right? It's not working so well. That's one of the reasons. There are new ones. There's a cell-based vaccine, and I already mentioned the recombinant vaccine that are not grown in eggs. So as time goes on, we may have other technologies that'll be useful. This would be great. We don't have this yet, but they're working feverishly to get a universal vaccine. Wouldn't it be great if we didn't have to guess? That we could identify an antigen that didn't change from year to year and use that as an immunogen in the vaccine. So we now have identified on the stem, I talked about the ball of the virus, on the stem of the virus there's also some hemagglutinin antigens, and what they're trying to do is those don't seem to change from year to year. So they're trying to develop a vaccine basically that would work for any influenza virus, including a pandemic strain, because that stays stable throughout all the different influenza viruses. So it's not clinically available. Around 5 or 6 years ago I said hopefully we'll have it in the next 10 years, but now it looks like it's going to be longer. But it's something that we should look forward to in the future. That'd be a great advance. So before we move on to pneumococcal disease, any questions about influenza? So pneumococcal disease is another disease. Influenza is the most important vaccine preventable illness as far as hospitalizations and death. Probably second to that is pneumococcal vaccine, where you get over 100,000 hospitalizations and in the thousands deaths from bacteremia and meningitis. So 65-year-old woman with no medical problems, no previous pneumococcal immunizations. Which vaccines should you give, in what order, and how much time between doses? Excellent. So that's a new recommendation. Give the 13 at 65, wait a year, and then give the 23. So that was a new recommendation in 2014, that you should separate them by a year. If patients have previously received the 23, then they should be given the 13 at least a year later. Okay? And that was based on this very large study in the Netherlands that showed that when we gave the PCV 13, we were able to decrease the number of pneumococcal pneumonias that people got. Pretty dramatic reduction. Let's do another case. 67-year-old healthy adult received the 23 at 65. What should we do? What do you think? So this was in before 2014, say this up. So they got the 23 at 65, which is appropriate because it was a few years ago. And now what should we do? They're coming in a couple of years later, so they're 67 now. Three, right? So then they're done, right? So there's no need to keep revaccination. So they already got the 23, it's been over a year, give them the 13, no more pneumococcal vaccines. These come up a lot, right? Let's do another one. 65-year-old with type 2 diabetes received 23 at 63 years old. What should we do? What do you think? It's an immunization lecture, so it's not going to be 4, right? Think about the timing. You gave her the 23 appropriately early, but she's diabetic. It's been 2 years, so you want to give the 13, but she got her first 23 before the age of 65, so you have to wait at least 5 years. So the answer would be that one, right? Because certain high, so we'll go over why that is. This is not just so when we see patients in the office, sometimes immunizations are put on the back burner. They could have a whole bunch of other medical problems going on. So we always have to remember that it's a really important health intervention, right? So a very large group of people, including asthmatics and smokers, get pneumococcal vaccine before the age of 65. And you can see all these COPD, liver disease, right, renal disease. There's many, many who get it. There's a very, very small group who end up getting 3 doses of the 23. But those are usually people who are sickle cell that have asplenia or severe immunocompromise, okay? So most people only get 2 in a lifetime, but there's a small group who get 3. I'm talking about the 23. How about 13? So I said you should get it routinely at 65 if it's been at least a year since they had 23. There's a much smaller group who get 13 earlier. So who is that? Those are people who have no spleen, chronic renal failure, CSF leak, cochlear implants, leukemia, lymphoma, or HIV. So that's a very small group compared to the group that got 23 before the age of 65. Doesn't this seem a little confusing? So they're reviewing it this year, and my gut feeling is they're probably going to try to simplify these recommendations, but I don't know. We have algorithms and stuff, but we'll see what they come up with. I don't want to, but I think that we may see some simplification of this process, because going through those cases, it can get a little confusing, right? And what's happened a lot, sometimes you don't know their vaccine history, because in the hospitals they're often getting 23 and we don't get it reported to us. So there's a lot of pros and cons right now, so we'll see. I don't know what the new recommendation will be. It's supposed to be either 2018 or 2019. So if we may be able to redo this lecture if we hear different recommendations. But for now, those are the recommendations. So to become comfortable with uncertainty is one of the primary goals in the training of a physician or any healthcare professional. Who said that? Osler, Sherwin Nuland, Michael Crichton, or Atul Gawande? Anybody know? That was Sherwin Nuland, who was actually a very brilliant surgeon and author. He went to Yale Medical School, and a very interesting part of his story, he was plagued severe depression and OCD, and he was treated adequately and then did a lot of really great things after he recovered from that. Osler is actually the physician who's really responsible for the way we train medical students and residents. He was very into bedside teaching, and he said, no, we can't learn just by looking at books. We have to see patients together, and so he kind of changed the way medical education went. He's also a practical joker, and he wrote a lot of textbooks, and he had a lot of great quotes. One of the best ones, listen to your patient, he is telling you or she is telling you the diagnosis. Michael Crichton never practiced medicine. He went to Harvard Medical School, but he became a writer, and he's the only creative artist in history to have simultaneous #1 status in the U.S. at the same time for TV, film, and book sales for ER, Jurassic Park, and Disclosure. So let's go to a case. And sometimes I've never had a patient hug me and say, Dr. Schlam, thank you so much for giving me that immunization, right? It's a non-event, right? You're given something that usually hurts and may have some side effects. But many years ago, I had a patient who came in. He was healthy in his It was 60, what does it say, 66, he was after 65. And so I drew up a Pneumovax and an influenza vaccine because it was in the fall. And then he decided he didn't want it. I pushed hard, I said, I think it's really important, but he refused it. Two months later, he got influenza, secondary pneumococcal pneumonia. Then he ended up getting renal insufficiency and C. diff, and he ended up dying actually from complications. So these immunizations don't, like influenza doesn't always prevent influenza, but especially in the elderly, but it oftentimes prevents the severe complication like hospitalization and death. Same thing with pneumococcal. So the point of that story is you never know how much good you could do. When you give a immunization, you may be doing something really important for that person. So it's a very important intervention. What are our barriers to immunization? So people oftentimes are fearful, but vaccines are very, very strictly. Now, there are side effects with vaccines. Most of them are local. Sometimes you can get some achiness and low-grade fever, but they're very, very rigorously monitored. So the vaccine adverse event reporting system, that's something that I or you could do, where a patient or anybody can do it. The patient can do it, where you report something. You got the vaccine, and then you report something that happened, right? So the correlation may not be great because sometimes you could think it's from the vaccine and it's not, but it gives us an idea in big groups of people. But it's a passive monitoring because it depends on people like us to report it, right? So it may not be that accurate. But it's something good because in big populations it gives us a trend that we better look into. The vaccine safety data link is prospective. That's active surveillance. So very large, there's millions of people in this vaccine safety data link, and big insurance companies do it, like Kaiser, that have their own health plan. And what they do is they give people a vaccine and they actively monitor them. So it's very effective in millions of patients to see, hey, something's not right. These people we gave the vaccine to, we're seeing a higher rate of something. So that's called so that's passive surveillance. This one's active surveillance. And the clinical immunization safety, that's more scientists looking, could this be a problem? So you guys still alert and concentrating? All right, I'm going to give you a quiz. You ready? You've seen this before? Did all of you see it before? No? Okay, you got this in your head? Everybody got it? Still with me? Yes? Still with me? You got a number? Still? Did I lose anybody? You got something in your head? Everybody have it? All right. So hepatitis B. Hepatitis B is a DNA virus with multiple envelopes, right? And the prevalence is, except in developing countries, it's common. In our country, the most common risk factors are multiple sex partners and intravenous drug use. And in the world, it's a very, very common cause of death in hepatocellular carcinoma. So I left out, who did I leave out for hepatitis B vaccine adult candidates? I left out an important group. Do you know who I left out? Good. Certain people from different countries, right? But who else? Who are we? What are we? Healthcare providers, right? Healthcare providers need to get, because we can have exposure, right? This is a recommendation that I often don't think of. So in diabetic patients under the age of 60, but also over the age of 60, just not as strong a recommendation, they recommend giving hepatitis B vaccine. The reason is there's been some outbreaks in long-term care facilities, probably because the glucometers weren't cleaned properly. So it's a recommendation that honestly sometimes slips by me because I don't think of it. Yeah. There's so this is new vaccine for Hep B. This is an exciting vaccine. So this vaccine is just, as opposed to the older hepatitis B vaccine, 0, 1, and 6 months. This vaccine is just given a month apart, and it's got a much more robust immune response. So this is not for babies. This is only for 18 and above. This is an exciting new vaccine that actually you can see the numbers. It's more efficacious and easier to give than the older hepatitis B vaccine. I'm not sure of the price of it. So we're going to switch gears and talk about pertussis, which can present just like a URI in the beginning, and then you start to get this awful cough. You can get the inspiratory whoop. You can get post-tussive vomiting, and you get these fits of coughing. Those are the three clinical things that make us suspect pertussis. In adults, they don't usually get those three, so it can be more challenging to diagnose. And children tend to get it the worst. If an adult or adolescent gets it, they tend to miss a week of school or a week of work, so it's pretty morbid. You feel miserable. And you could see when we started to immunize with whole cell pertussis, we had a dramatic decline. But you can see over the last 20 to 30 years, we're seeing the rates go back up. And it turns out that's the tip of the iceberg. Pertussis is probably much more common than what's reported. This is difficult to diagnose. You have to do a PCR, nasopharyngeal swab, very uncomfortable to do. And it's sometimes the presentation can be very much like a URI or bronchitis, viral bronchitis. So which of these individuals is at highest risk if they get pertussis? The babies. So under the age of 6 months, if they get pertussis, they can have a higher rate of sudden death, actually. So that's why the cocooning strategy, we're the only individuals right now who should get repeat Tdaps, is pregnant women in the 3rd trimester, because we're trying to protect the baby. So those patients will get a Tdap. If they have a baby, they get one a year later or 2 years, right? Every time they get pregnant in the 3rd. So we want to immunize grandparents, siblings, anybody who's around the baby to make sure we get maximal protection. That's the cocooning strategy. So we have these four, so that's a cartoon of the pertussis bacteria. And these 4 antigen is what's in the acellular pertussis vaccine. When we had the whole cell pertussis vaccine, it worked better, probably. We see that now retrospectively. But there was a lot more reactogenicity, fever, even seizures from it. So what happened is they made the acellular pertussis vaccine, which is a refined vaccine. They used these antigens as immunogens and cut down on the reactogenicity, but it probably also reduced the efficacy. So it's still a great vaccine, but may not be as efficacious as the older vaccine, and that's one of the reasons, maybe the most important, why we're seeing increased rates of pertussis. So rash, fever, headache, we're all worried about this person. Stiff neck, what is this? Meningococcemia, right? Very good. So this is caused by Neisseria meningitis, and this is very scary. It can present like a URI, and then they could be dead within 12 to 24 hours. And the good news is, and this is not because of immunizations, right? So we're seeing a dramatic decline in the rates of meningococcal meningitis in our country. Dramatic decline. We used to see, thousands of cases, maybe 3,000 to 5,000 cases a year in our country. Now we're seeing under 1,000, closer to 700 a year. We're not sure why that is, but it's a good thing. So close to about 700 cases we've been seeing a year, but the problem with this, even though it's not common, 700 cases in a year is not common in a large country, but 10% mortality, 15% neurological deficit or limb loss, so it's got a lot of morbidity and mortality, and that's why it's important to immunize for it. It's a very important, so if you're going to sub-Saharan Africa in the dry season, you should get the ACYW135 vaccine, the one we give routinely to travelers, because A is the most common one if you're going to sub-Saharan Africa. If you're going on a Hajj pilgrimage, W135 is the most common, right? In our country, the most common is C and B. C is in this vaccine, B is, you have to get a different vaccine. Okay? But it's very good for travelers who are going into higher risk settings. And that's just illustrating which countries had which serotypes. These are some high risk groups that are targeted for immunization. And these are some of the meningococcal vaccines that are available in our country. So we've seen some outbreaks of B that have been very, very heavily publicized. A lot of them have been in college settings. As hard as this is to understand, despite these outbreaks, it's that age group, it's not being in a college that does it. So the data doesn't support that this is related, that it's just about being in college. It's that age group that tends to get it. That's hard because we hear about the outbreaks in schools, but that's not what the data showed us. They're not at higher risk than other people of that age. But we tend to give it to them because that's the age group a lot of the students are going, and That's it's a B recommendation. So it's not something you have to have, like the quadrivalent vaccine from meningococcal. It's something that you discuss with them. Okay? But it's a reasonable, because of the severity, even though it's a rare disease, it's got such severe consequences, why it's a reasonable thing to vaccinate against. These are higher risk groups that we talked about. When they're talking about the college students, they're talking about both vaccines, ACY, W135, and B. Switch gears to Hep A. So Hep A, we've seen some outbreaks in our country, actually recently. And these are the risk factors. Most of them, up to half, are unknown. Who should get it? Persons with chronic liver disease is key. Now we're immunizing infants routinely. We're trying to eliminate hepatitis B, but a lot of people come from other countries and where it's endemic, right? And this is concerning. We've had some pretty large outbreaks in our country in the last couple of years. You can see if you're traveling somewhere, pretty much the entire world except the developed countries, you're at risk. This is a very important travel vaccine. If you're over the age of 40, immunoglobulin in the CDC still recommended over Hep A. Under the age of 40, just give Hep A even if you're leaving that day or even after you stepped off the plane to go to the high-risk country. But most people who do travel medicine, we do that in our office, we just give Hep A. We don't even stock immunoglobulin anymore because we feel that Hep A is a better alternative and works just as well. So Hep A, immunoglobulin is not something that we have to do for our travelers. I would prefer Hep A. One dose, repeated at least 6 months later, we hope gives you lifetime immunity. What does that kid have? Measles, excellent. And measles used to be endemic in our country before immunization in the early 1960s. And now we've had a major outbreak between 1989 and 1992, and we had a more recent outbreak in 2014, but it was over 600. Now we're seeing in the hundreds per year. Very contagious, and those are the complication rates. So that was a big, in 2014 we had a lot of cases. So far in 2018 we've had 107 cases. So still around because immunization rates, we have to get more people immunized against MMR to really decrease the rates of measles. That's just over the last 7 years, the number of cases we've had in the United States that were reported cases. This is a live virus vaccine, so you can't give it to people who are immunocompromised or pregnant. And what does that young man have? Mumps. So we're seeing a lot of, these are some of the complications, parotitis, orchitis, but we've seen some big outbreaks of mumps. And you can see in 2017 and 2016, 5,000, 6,000, so a lot of cases of mumps. So we got to do a better job immunizing with MMR, right? And sometimes there has been no connection with MMR vaccine and autism. It's been looked at pretty rigorously, very rigorously, and there's no connection. So, a Spanish teacher asked her class if the word for computer was masculine or feminine, and the class was split into two groups. She put the women on one side and the men on the other. And the males say that the computer, la computadora, is female because no one but their creator understands their internal logic. The native language they use to communicate with other computers is incomprehensible to anyone else. Even the smallest mistakes are stored in long-term memory for possible later retrieval. And as soon as you make a commitment to one, you find yourself spending half your paycheck on accessories for it. And the females say that the computer is male, el computadoro, because in order to do anything with them, you need to turn them on. They have a lot of data but still can't think for themselves. They're supposed to help you solve problems, but half the time they are the problem. And as soon as you commit to one, you realize that if you waited a little longer, you could have gotten a much better model. The women won that contest. So let's talk about HPV. Those are the large ones that cause, those are the larger ones that are due to 6 and 11, 90%, very preventable with the vaccine. But this is a very, very common infection, HPV. Very common in the general population. As a matter of fact, the vast majority of people get infected, and most of those people just get rid of it. But a minority don't, and those are the people who can run into problems. And it's the cause of cervical cancer, but it's not just cervical cancer that are caused. It can cause vulvar cancer, vaginal cancer, penile cancer, anal cancer, oral pharyngeal cancers. So this is an anti-cancer vaccine, very important. Do you know of another anti-cancer vaccine? Hepatitis B, right? So hepatitis B, we can prevent liver cancer with that. This is our second anti-cancer vaccine. And now we have HPV-9, which protects against over 81% of the serotypes that cause cervical cancer. It also has 6 and 11 in it, which cause 90% of those visible warts that I showed you earlier. And these are the vaccine recommendations. It's routine at 11 to 12. It's better to give it earlier at 11 to 12. The youngest you can give it is 9. The reason is once they've been exposed to the virus, the vaccine's not going to be helpful because they already got the virus. So you want to get them before they're exposed to the virus, and also you get a more robust response to the vaccine when you're younger. So there is now a 2-dose series. If you're under the age of 14, you only need 2 doses, not 3. If you're over 15 and above, you get 3 doses still. Another reason to get it younger is better. And we have to do a better job of promoting this vaccine because it's a very important vaccine. We've had 2 patients, one in their late 30s and one in their mid-40s, very unusual, that died in the last 5 years in our practice from cervical cancer. So that's preventable with this vaccine. So it's definitely a worthwhile vaccine. What does this guy have? Good, chickenpox. Very good. Another vaccine preventable. This is another live virus vaccine, so you can't give it to pregnant women or people who are immunocompromised. And what does this gentleman have? Shingles, right? That's Herpes Zoster. See, it stops at the midline. So there are about 1 million cases in our country every year. If you make it to the age of 85, there's a 50% chance you'll get shingles, and about 1 out of 3 people in their lifetime get shingles. That's the vaccine that we were giving in the past, a live virus vaccine. Same thing that's in the Varicella vaccine. It's at 14 times the potency. It had decent efficacy, but it was live virus, so you couldn't give it to people immunocompromised. But now the new vaccine is Zostrix, which they had a huge study of over 38,000 patients, and the efficacy was much better than with the older Zostavax vaccine. And it's not a live virus vaccine, it's a subunit vaccine. It's not approved at this point for immunocompromised people, but theoretically it shouldn't be a problem. But it hasn't been approved for that yet. This is it. So the other vaccine was a 1-dose vaccine. Unfortunately, the immunity probably waned pretty significantly by 4 years. This vaccine is a 2-dose vaccine, but it's got a much more robust response as far as protection, and it probably lasts a lot longer. We don't know how long it's going to last, but the data looks good that it's going to last longer. So this is an unusual, ACIP, the Advisory Committee on Immunization Practices, those are the people who decide for the CDC what the immunization practices are going to be. They actually voted Shingrix over Zostavax. That's very rare that they vote for one vaccine over another. So they actually said that was the preferred vaccine. So we should be giving Shingrix instead of Zostavax. You can see in the elderly especially, who those are the people who are at the highest risk, 91% versus 18% of efficacy. So it maintained efficacy as you got older. The Zostavax doesn't do that. This is just a comparison of the 2 vaccines. Unfortunately, Shingrix, almost everybody, 70% of people get low pain and swelling and discomfort at the injection site. Another percent can get muscle aches or low-grade fever. So there's more reactogenicity. But in this study with 38,000 patients, despite that, people came back for the second shot. So it's got to be at least 2 months later. You want to give between 2 and 6 months later for Shingrix. So immunizations in the future. We don't like shots, and this is something that'd be really exciting. They've tested it now with measles and influenza. How about an immunization patch? So they have these little polymer bumps on this, and that's coated with vaccine. You put on a patch, doesn't have to be refrigerated, and the immune response is as good as if you got a shot. So you could just deliver boxes of it. You don't need a health professional to put that on. So that's really, it's not prime time yet, but that'd be great in the future to have something like this, right? Really a big advance, and it looks like it's going to happen. This technology looks very good. We actually already have a vaccine for malaria, but it's not very effective, but there is a vaccine not to be given to travelers in developing countries. We're looking at better vaccines for tuberculosis. The BCG is just to protect against CNS tuberculosis, not pulmonary. And HIV, still no vaccine available. They've been trying to work on that for many years. So there's many more than this in development. There's always a lot of vaccines in development. There's a lot of very generous people who have foundations who are looking to improve immunization rates, not only in our country, but in developing countries. Let's do another case. 65-year-old wants to volunteer at the newborn nursery in the local hospital. She's healthy, and she's only on a medication for cholesterol. Any immunizations that should be recommended? What do you think? Excellent. Tdap, because she's at a newborn nursery, right? So you want to give her something to protect the infants against pertussis. Good. Influenza, absolutely. Very important. Yeah, she's had them. But what else? What do we give at 65? 13, right? And what else might you want to give her if she wants it? The new vaccine. Right, you can give her Shingrix, right? So this is old. I should have corrected. It should be Shingrix, not Zostavax. Those are some good numbers and websites. Immunize.org is an excellent website. 50% of what we learn in residency in medical school is no longer true. I used to say 10 years later. Now I change it to a year. Because the data keeps changing and the recommendations keep changing. So it's not just with immunizations, with every topic. But with immunizations, you really have to look up each time. Because they're changing recommendations at a regular pace. So I flew through that at a rapid rate. Does anybody have any questions about any of the things that we spoke about? If you got the vaccine? So that's a really good question. So you should not get shingles if you never had chickenpox. So the answer to your question is you should not. The interesting thing, can the vaccine strand, the live virus strand, predispose you? There's no data to suggest that. It's a weakened virus. You shouldn't get that from it. That's a real. Is it possible? No, probably it's possible. Anything's possible. It's not like it's a really interesting and good question, but the answer to that is it's very, very unlikely, right? So that problem, so varicella, so if you're born after 1980, 99.5% of people, 99.5, so 199 out of 200 people, they had varicella even if they didn't know they had it. So the recommendation, so the younger people are getting the varicella. They can sometimes get some breakthrough chickenpox. The question that comes up, so it's a younger population, you're not going to be giving them this vaccine anyway. What happens with the what if you already, I'm going to take yours and take it a little further. So what if you already got the Zostavax? Should you still get the Shingrix? And the CDC says yes. How much after? You have to wait at least 8 weeks. I probably will wait a little longer. How about if you already had shingles? Should you get the vaccine? Well, there's about a 1% to 4, so 1 in 100 to 1 in 25 people, even they can get shingles again. And the older they are and the more immunocompetent, immunosuppressed they are, the more likely to get it. So the recommendation is get the Shingrix, even though you've already had the shingles once. But if it was me, and this is not evidence-based, if I just got shingles, the actual disease, I wouldn't get the vaccine right away or 8 weeks later. I wait a while because you already boosted your immunity. This is the only immunization where you're protecting against something that's hanging out in your dorsal root ganglion. It's already in your body. And what you're trying to do is boost your immunity to keep it there. That's what these vaccines do. So you already boosted your immunity when you get a natural infection. How long to wait? Nobody knows. Right? But you probably wait at least a couple of years. But there's no data to show how long to wait. So you would get it, but I don't. So there's the flu vaccine. Is it 100%? No. This past year was a very interesting situation. So what we think happened is the flu vaccine sometimes doesn't work as well as we'd like, even in the best of circumstances, not 100%. But what happened this year is it wasn't that there was a drift in the actual wild, the flu virus that was out in the community and circulating. While it was being grown in eggs, they thought the vaccine virus somehow changed a little. That's the theory. And so it didn't work quite. That's the first time that's been, so that was I'm talking about just this past flu season. So it was a little different than the usual drift that I talked about before. But what I tell people is, I think it's a very important health intervention. Rarely flu can kill people, and it does help protect you somewhat. Nothing's 100%, but if you got a flu vaccine, it's certainly better than not getting a flu vaccine. The younger you are, the better the protection is. But the very young, not as good, but I'm talking about like adolescents and young adults. The better the protection is. So if people tell you that, they say it is protection. It's not 100%, but it gives you a much better chance of not getting severe complications from influenza. Right? It cannot give you the flu. So it can't give you the flu because it's not an activated, so it cannot give you the flu, but the most common thing is pain and redness and swelling at the injection site. And you can get some achiness, fatigue, and low-grade fever after a flu shot. Yes. Right. And a lot of times what happens is people get the flu shot, and we give it in a time where people have a lot of circulating, and they have another virus they may attribute to the shot. But the shot itself can do it too. Those the ones that I told you about, the two of them, for not the recombinant so much, but the other two, those will give you more systemic side effects. Fluad especially, I don't use that one as much, but that one, up to 17% people have more achiness, low-grade fever. So it doesn't actually give you influenza, but it can give you some, but it's much better than getting actual influenza, which will really knock you off your feet if you get influenza, and put you at risk for hospitalizations and death even. ACIP, they said it's okay for this year. What ended up happening, the randomized control studies showed that it worked. But they do field work on these vaccines, meaning what are the rates of influenza. And the shot had, this was not last year, the year before, but the shot had about 50 to 55% protection. The nasal one, over those 2 years that it wasn't approved, had like 3%. Like it just didn't work at all. So I would not use it yet. That's not, just my personal bias is, unless they're really needle phobic and you can't give them the shot, I wait and see what happens this year. I wouldn't give it. I used to like it because it's good for people who don't like shots, right? But there's a large group of people who can't get it, including pregnant women and age group and asthma. Try not to give it because there's a relative contraindication. So for now, I would stick with the shot. That's my bias. That's not the ACIP, but that's what I would do. I know it's more uncomfortable, and people don't like shots, and I don't blame them, but that's what you're getting it. And you're getting protection, but nothing's 100%. Just like a lot of things that we do, a lot of interventions we do, they don't work 100%, but they're certainly better than not getting the intervention. No other questions about immunizations of any type? No? Thanks for your attention.